Hi, it's Dr. Cherry doing a quick talk today to guide you through what you might want to know as you prepare for the team-based learning activity on headaches. If you want, you can use this as a guide to accompany the slides, or you can listen to this as an audio-only recording. It's kind of like a podcast. So if we get into our learning objectives for the session, we're going to want to differentiate between the symptoms and presentation of the main types and categories of headache. For example, that might include primary headaches that are caused by the headache itself versus a secondary headache, which is a headache caused by something else going on in the body. We'll be talking about trigeminal neuralgia, migraines, cluster headaches, tension headaches, sinus headaches, post-traumatic headaches, pseudotumor cerebrae, other physiologic headaches, and medication overuse headaches. As you prepare for potentially being tested on this material, you'll want to have a good idea of being able to not only define those types of headaches, but also knowing their key characteristics as well as potential treatments for them. For our second learning objective, we'd like to be able to define the pathophysiologic process and risk factors that might trigger each type of headache and be able to interpret and respond to red flag symptoms. What that means, of course, is that there's a huge continuum of headaches, and we want to know which ones are going to be acute, life-threatening issues and which ones are going to be run-of-the-mill, everyday headaches. Finally, we'll want to explain how a relationship between inflammation and pain provides a therapeutic target for analgesics. If we go on to the definition of what a headache is defined as pain arising from the head or the upper neck of the body. One thing that's really interesting is that since the brain itself contains nerves that don't have pain fibers, the pain that we feel with headaches originates from tissues and structures that surround the course through the skull or the brain. A way to think of that is that the brain is not necessarily causing the headache, but it might be something that the brain is pressing on or something contained within the brain itself that is causing those headaches. Now, the pain from headaches might be dull, it might be achy, it could be sharp, throbbing, constant, intermittent, mild, intense, or even a combination of all of them. So those are good words as we extend our definitions and our ideas into our clinical courses to be able to describe what a headache is. Moving on to the categories of headache. There are at least 3 major categories of headache, and they're based upon the source of the pain. So primary headaches are going to be from those pain structures in the head and the neck being stimulated. Those might be things like tension headaches, migraine headaches, cluster headaches. They might be due to the meninges, the blood vessels, the nerves, or muscles, inflammation occurring in any or all of those areas. A secondary headache, however, is due to another underlying disorder. Finally, we'll be talking about cranial neuralgias, facial pain, and other headaches. Going into further detail on those definitions, the primary headaches, again, are those headaches in which the associated features are the disorder itself, and secondary headaches are those caused by exogenous disorders. For example, a mild secondary headache is most often associated with upper respiratory tract infections. It's very common, but rarely worrisome. On the other hand, a life-threatening headache is relatively uncommon, but vigilance is required to recognize and appropriately treat them. Some red flag symptoms that might indicate, hey, this is a headache that needs further evaluation, include things like an age over 50, a pattern change. For example, if somebody comes in saying, this is the worst headache of my life, that merits attention. It could be a positional headache or a headache that's moved when a person changes position. We'd be looking for precipitating factors for a headache that started and came on with a person sneezing, coughing, or having exercise. That might indicate, for example, some type of vascular insult. We'd also be looking for any high-risk events in the history, things like fever, cancer, or trauma. Finally, and perhaps most importantly, we want to look at physical examination findings, such as papilledema and neurologic deficits. Next, we're going to talk about trigeminal neuralgia. Now, trigeminal neuralgia is intense. It's typically unilateral, it's paroxysmal, and it's a stabbing pain in the sensory distribution of the 5th cranial nerve or the trigeminal nerve. It's also known by the name tic douloureux, or the painful tic. It's most often localized to distributions of the mandibular, V3, or maxillary, V2 divisions of the trigeminal nerve. We don't see nearly as many with V1. Pain type usually has a spontaneous onset, and it's often associated with a trigger, such as touching or moving the tongue, lips, or face, speaking, chewing, shaving, brushing teeth, applying makeup, blowing one's nose, being exposed to the wind, or drinking hot or cold fluids. The pain attacks are often stereotypical. They're caused by the same triggers in the same location for the same person. And the patient is often pain-free between the paroxysms of the trigeminal neuralgia. A person may also describe having remissions that last several months, and then they're exposed to the same trigger, and they end up with the same type of pain. Trigeminal neuralgia, if we remember the trigeminal nerve as being primarily sensory, trigeminal neuralgia is not typically associated with obvious motor or sensory deficits. It's really just the pain fibers that course along the trigeminal nerve. Moving on to migraine. Migraines are recurrent, episodic headache attacks that may or may not be preceded by a focal neurologic symptom called an aura. Migraine definitions go on a little bit further to describe, for example, a migraine with aura, which is known as a classic migraine. There's also a migraine without the aura, which is a common migraine. Chronic migraine is a definition for a headache that occurs 15 or more days per month for 3 or more months. Finally, status migrainosus is an absolutely horrible thing to experience, and that's a debilitating migraine attack lasting 72 hours or longer. Let's talk a little bit about the aura, and we're going to move back and forth here to go along with the slides, but again, the slides aren't necessary if you are listening to this in audio-only mode. A migraine with aura usually causes visual disturbances for about 30 minutes prior to the initial migraine symptoms. That aura can, of course, be just the visual disturbances, but it can also affect speech or taste or smell. Sometimes people will describe it as having a part of their vision go totally blind, where they can't see, for example, in the periphery or center of their vision, and it moves over time. Others will describe seeing floaters or sparkles. Any of those things might be the aura. Now that's different than a migraine without aura, which is a headache that comes in stages. The migraine without aura, that person may experience nausea, fatigue, irritability, sensitivity to light and sound, and it's typically a localized spot on one side of the head. Now, remember, even though that headache, the migraine without aura, can include a sensitivity to light and sound, we're not necessarily seeing the visual disturbances preceding the migraine symptoms that you would see in a migraine without aura. Moving on to the stages of a migraine, or the clinical presentations, we'll often talk about a prodromal phase. Now, a prodromal phase might last for hours or days, and it typically involves fatigue or difficulty concentrating. Then we move into the aura itself, which is associated with a typical migraine attack, and it usually has at least one of the following keyword here: fully reversible symptoms. Aura symptoms are fully reversible, which is one of the things that distinguishes it from a TIA or a stroke. The fully reversible symptoms might include photophobia and or phonophobia. There might be visual effects. These are the most common, such as flickering lights, spots, lines, or negative features of vision, such as a loss of vision in a specific spot, sometimes unilaterally, sometimes bilaterally. There may be sensory symptoms, including what we might call positive features like pins and needles, and negative features like numbness. Speech and language symptoms are also sometimes affected, where a person might say that their speech is not as clear as they'd like it to be, or they're having word-finding difficulty. That again comes and goes. If we're looking at the typical migraine, it's going to have at least two of the following characteristics. It's going to be a unilateral location. Quick note to the listener, compare that to later when we talk about tension headaches that are often not unilateral. The migraine, in addition to being unilateral, is going to have a pulsating quality, and it's going to have a moderate to severe pain intensity. It's often aggravated by or causes an avoidance of routine physical activity, and that's because physical activity may worsen it. Family history of migraines are incredibly common. Most people who have migraines may describe a family member who had similar headaches. A person may go a large part of their life without a migraine, but then due to aging or hormonal changes, they may experience their first migraine after a period of physical activity, after a period of decreased sleep, or after some unusual activity such as, say, an international flight or being dehydrated. In further definition of the migraine phases, we can talk about the prodrome as the period leading up to the migraine. This is when auras occur. The prodrome phase can affect concentration, mood, and appetite, and this phase can also cause frequent yawning. The peak headache, however, is the period when migraine symptoms are the most severe. This phase can last for several minutes. The postdrome is what follows. It's usually about 24 hours after the migraine, and during this time, drowsiness can occur, mood can fluctuate, and it can often go between feelings of depression or euphoria. A wide range of mood possibilities can come in the migraine prodrome. In the slides, I do have additional terms that might describe first, second, third, all the way through sixth phases of migraine. Those ones are less commonly used, but they sometimes can be helpful for noting where we are at the stage of a headache. One thing that I do want to point out is the utility of triptans, such as sumatriptan, as an abortive agent for migraine headaches is limited. It's usually once a person begins to have the prodrome or premonitory phase or the aura, but by the time that the headache reaches its acute phase, it is more difficult for triptans to be able to be effective. We're moving on now to talk about tension headaches. Tension headaches are commonly used to describe a chronic head pain syndrome that's characterized by bilateral, tight, band-like discomfort. This is much different than some of the headaches we've spoken about already that are often more unilateral in distribution. Tension headache pain typically builds slowly, fluctuates in severity, and may persist for a short time or continuously for many days. These headaches may be episodic or chronic. A chronic tension headache, similar to a chronic migraine headache, is looking at a definition of being present 15 or more days per month. The pathophysiology of a tension-type headache, or TTH, is not completely understood. There certainly may be a genetic contribution, but it's often a product of nervous tension or stress, sometimes muscle tension. Therefore, the pain of tension headache, if we think about it perhaps as a muscular tightness or a neurologic imbalance, it's often generally managed with simple analgesics such as acetaminophen, aspirin, or NSAIDs. The next type of headache that we'll discuss are cluster headaches. Even though migraines are tremendously severe and uncomfortable and may lead to all sorts of symptoms for those who experience them, cluster headaches are often considered the most severe type of common headache. This pain is typically intensely burning or piercing, and it's located behind one or both eyes. On the side of the pain, physical exam findings may include an eyelid that's drooping, with reddening of the eye and constriction of the pupils. These headaches often happen in groups or clusters, hence the name, and these may occur 1 to 3 times per day during the cluster period, which can last 2 weeks to 3 months. A headache attack will usually last 15 minutes to 3 hours, and these may go into remission for months or years. Men are at least 3 to 4 times more likely to get cluster headaches than women. Moving on to sinus headache. Sinus headaches are deep and constant pain that's located near the sinuses. Patients will come in describing these as pain in their cheekbones, their forehead, or on the bridge of their nose. These occur due to inflammation of the paranasal sinuses and is associated with a runny nose, fullness in the ears by means of inflammation likely through the eustachian tube, and fever. Because this is a sinus headache that's due to inflammation of the paranasal sinuses, it shouldn't surprise us that initial management is by antihistamines and nasal decongestants, followed by broad-spectrum antibiotics if necessary. Please note that this is a significant difference from the way that we would treat tension headaches if we think about how those are caused by nervous or muscular tension, leading to anti-inflammatories as an appropriate treatment, and differently than we would treat our migraine headaches when we were talking about things like our triptans. Moving on to post-traumatic headaches. Post-traumatic headaches, as the name sounds, occur after some type of head injury. They usually start 2 to 3 days after the head injury, and they begin with a dull ache that may get worse and remain constant. They're associated with concussions, but concussions are not the only cause of post-traumatic headache. The word concussion is used to describe the situational change in the mental status in the absence of intracranial pathology on CT scan. That's to say that a post-traumatic headache may occur with or without concussion, and likewise a concussion may occur with or without a post-traumatic headache, especially if we think about concussion being used specifically to describe the change in mental status in the absence of intracranial pathology. Symptoms of post-traumatic headaches are nonspecific, and they can be associated with vertigo, irritability, and difficulty in concentration. The degree of symptoms that we see from a post-traumatic headache is not predictive of the severity of the trauma. What that means is that a trauma that is actually fairly severe can have a very mild headache, and likewise a very mild trauma might have a much more severe headache. This condition usually does not require treatment and resolves on its own, although certainly pain relief may be considered. Moving on to pseudotumor cerebri, or pseudotumor cerebri. Under normal conditions, we make and resorb our cerebrospinal fluid volume in about 6 to 8 hours, and we remember that cerebrospinal fluid is made in the choroid plexus and reabsorbed in the arachnoid villi. In benign intracranial hypertension, which is synonymous with pseudotumor, there is too much spinal fluid, either through too much production or not enough reabsorption. So there's a problem with the plumbing leading to too much CSF. This is most common in obese women of childbearing age, and papilledema is present in a majority of cases. Associated symptoms include visual distortions and tinnitus, and the diagnosis may correspond with vitamin A intoxication and thyroid disease. I'm going to repeat that last part because these are critical things that may show up on physical exam or if one is reading a question stem. Papilledema is something to be looking for, which may be associated with visual distortions. Tinnitus, vitamin A intoxication, and thyroid disease are all potential risk factors for papilledema. Treatment for pseudotumor involves addressing the underlying causes, such as weight loss, using standard headache treatment, using carbonic anhydrase inhibitors, high-dose steroids, using repeat lumbar punctures to relieve pressure, or for refractory pseudotumor, having a lumboperitoneal or ventriculoperitoneal shunt, and finally, optic nerve sheath fenestration. Be familiar with how papilledema would look on an ophthalmic exam. Next, we're going to cover a wide variety of other physiologic headaches. There's at least 8 of these that I am going to talk about here. Tumor, of course, can cause headaches, but those headaches, if we think about the growth of a tumor or of neoplasms, are usually chronic and progressive, with neurologic deficits corresponding with the area of disruption. Neurofibromatosis and tuberous sclerosis also have a frequent intracranial pathology. For those with systemic hypertension, they may also experience physiologic headaches. This is because the brain regulates cerebral blood flow by increasing the intracranial pressure. With mild to moderate elevation of blood pressure, intracranial pressure is still maintained in the normal range. But with high blood pressure, ICP can be elevated enough to cause symptomatic headaches. And people with chronic headaches may have high circulating catecholamines and elevated blood pressure secondary to pain. High blood pressure and its corresponding headaches can have variable causes, and these might include things like pheochromocytoma, abnormal thyroid hormone, impaired kidney function, drugs of abuse, and even the increased pressure that occurs from hypertensive episodes during obstructive sleep apnea. We should also talk about temporal arteritis. Temporal arteritis is a medical emergency in which throbbing unilateral temporal pain is present. Temporal arteritis should be suspect in anyone over age 50 with a new onset unilateral headache, especially in the area of the temples. The diagnosis and treatment here are commonly tested, and this is really a presentation worth knowing. It's diagnosed with a temporal artery biopsy, and an erythrocyte sedimentation rate can be a useful screening test, or an ESR. Treatment includes steroids as the primary mechanism for treating this type of severe, life-threatening inflammation. Infections can also be associated with physiologic headaches, both in acute headaches and chronic infections. Potential causes can range as far as strep pharyngitis to meningitis. Be looking for, of course, the physical exam findings that go with that, abscesses, dental issues, sepsis, URIs, really anything that causes inflammation can also cause headaches. Venous thrombosis is worth mentioning as this may mimic intracranial hypertension. It's often associated with headache, papilledema, and a key here is small ventricles on imaging. It can be spontaneous or associated with trauma, pregnancy, infection, or malignancy. The key here is, again, really to look at the imaging and see if you see stagnation in the veins of the head area, especially related to the subdural areas. The subarachnoid hemorrhage is perhaps the most acute presentation of all. This is where a previously healthy person presents with an intense headache that develops over seconds to minutes. It's also called a thunderclap headache, if we think about the way that thunder occurs. It's diagnosed through a CT scan, through a lumbar puncture looking for xanthochromia, and requires immediate neurosurgical consultation. We should also mention headaches due to stroke and or transient ischemic attacks, or TIAs. In these cases, we're looking for associated neurologic deficits. We want to distinguish these from a migraine with aura, which we recall can also include some temporary, reversible neurologic episodes. Finally, medical illnesses have a wide range of causes from referred pain. These can include hormonal changes, renal disease, pulmonary disease, endocrine diseases, and other disorders. One of the most common things that you will see as well in clinical practice is a medication overuse headache. And this describes a headache that occurs 15 days per month or more as a consequence of the regular overuse of headache medication in patients with a pre-existing headache. This is most common in migraine-type headaches and all abortive headache medications, including common over-the-counter things like our NSAIDs, can lead to a medication overuse headache. This creates a vicious cycle where a person has headaches, so they use more medication, and then the more medication leads to more headaches. The treatment here is to try gradual reduction and discontinuation of the overused medication.